Start.
Good afternoon, everyone. Today I'm going to give a seminar on topic treatment guidelines on LRTI, that is lower respiratory tract infection. So, lower LRTI is infection that is below the larynx. It includes trachea, lungs, and bronchioles. So I have divided the topic in bronchitis, then bronchiolitis, and pneumonia. So first, bronchitis. Bronchitis is the inflammation of the bronchioles, and the inflammatory process, it doesn't extend up to the lungs. It will remain only up to the bronchioles. So the first treatment for the bronchiolitis is to reduce the inflammation. So we'll give aspirin or acetaminophen 650 mg in adults. In case of pediatrics, it's 10 to 15 mg. So in pediatrics, acetaminophen is not recommended because of the risks of Reye syndrome. Reye syndrome is like inflammation in the brain, which occurs confusion in the babies and causes the liver damage. So instead of aspirin, we will prescribe the acetaminophen instead in pediatric, or we can give ibuprofen 200 to 800 mg in adults, or in case of pediatrics, it's 10 mg per kg per dose. That's it. Then if the symptoms is mild and the cough is persistent, then we'll give the dextromethorphan. It is an antitussive agent, and the dose is 10 to 20 mg per hour every 24 hours. So if in this case, if the fever is not there, then we don't need to start the antibiotic therapy. But if the fever is persistent for more than 4 to 6 days, then we have to start the antibiotic therapy, which includes amoxicillin clavulanate per oral every 12 hours, where the amoxicillin dose is 500 mg and clavulanate is 125 at least for 10 days. Or we can use azithromycin 500 mg once in a day, which is followed by 250 mg for 2 to 5 days. So if the patient is having penicillin allergy, then we can go for the fluoroquinolones, that is levofloxacin or ciprofloxacin or moxifloxacin. The dose is 750 mg per oral once in a day, 7 to 14 days. Or we can also go with the tetracycline, that is doxycycline 200 mg per day, twice in a day. So this is for acute bronchitis. So in case of chronic bronchitis, the sputum will be more in that. So we'll use the mucolytic agents. Also we'll use the combination of long-acting beta-2 agonist and inhaled corticosteroids. If the symptoms are mild, then we will just use oral aerosolized bronchodilators, which is albuterol aerosols every 2 to 4 hours, and it contains 2.5 mg every 1 hour. Then we'll use the combination of long-acting beta-2 agonist and the inhaled corticosteroids, which is salmeterol and fluticasone. We'll use this both combination, in where salmeterol dose is 50 mcg and fluticasone is 500 mcg, one inhalation 2 times in a day. Or we can use ipratropium, which is 0.5 mg every 6 to 8 hours. And if for the antimicrobial therapy, you can use the same antibiotic therapy as in acute bronchitis. So the next one is bronchiolitis. So this bronchiolitis, it's affect mostly in infants. In adults, it's less. So here this one is self-limiting disease. So no need of any treatment in case of mild, and we can only relieve the symptoms by using the antipyretic agents and any painkillers. But if the disease is severe, then we can use the ribavirin, in which the adult dose is 6 gram over 12 to 18 hours if the patient is ventilated. If the patient is non-ventilated, then we can use the less dose, 2 gram over 2 to 4 hours. So now next one is pneumonia. So we have 3 types of pneumonia: community acquired pneumonia, then hospital acquired pneumonia, and ventilator acquired pneumonia. So in case of community acquired pneumonia, if the organism is Streptococcus pneumonia, then we can use this antibiotic, which one is amoxicillin 1 gram per oral 3 times in a day, or azithromycin 500 mg followed by 250 mg 2 to 5 days, or doxycycline 100 mg 2 times in a day. This is the treatment guidelines if the patient is healthy, that is if the patient don't have any comorbidities, only he or she is affected with the pneumonia. Then in case of influenza, if the patient is if the patient had the organism influenza, then we will use oseltamivir 15 mg once in a day as a prophylactic. or twice in a day for a treatment. Then if the patient is having the comorbidities like diabetes, heart disease, or any other kidney disease, then we have to increase the dose, and we can add the macrolides like azithromycin, or we can add the doxycycline in this regimen only. That is amoxicillin clavulanate 2 gram per 125 and 125 mg twice in a daily, or cefodoxime 2 times, or cefuroxime, which is 200 mg and 500 mg plus macrolides, or we can also use the fluoroquinolone, same dose as this one. So in case of ICU patient, we can use the beta-lactam antibiotics plus macrolides, same like this one only. And if the patient is penicillin allergic, we can use the fluoroquinolones and azithromycin. Azithromycin is the monobactam. Now, if the organism is Pseudomonas, then we can use Piptas 4.5 gram every 6 hours, or the 4th generation or 3rd generation cephalosporin, that is cefepime or ceftazidime, which is 2 gram per every 8 hours. Now, in case of methicillin resistant Staphylococcus aureus, we can use the vancomycin 15 mg per kg every 12 hours, and linezolide 600 mg every 12 hours. Now, the next type of pneumonia, hospital-acquired pneumonia and ventilator-acquired pneumonia, the treatment is same for both of these. So, if the patient had no risks of MDR, that is multi-drug resistant pathogens, we can use this ceftriaxone or fluoroquinolones, that is levofloxacin, or ampicillin and sulbactam, or itrapenum or doripenum. The ceftriaxone dose is 2 gram IV or oral every 24 hours. Fluoroquinolones 750 mg every 24 hours. Ampicillin or sulbactam 3 grams IV every 6 hours, whereas itrapenum and doripenum dose is 1 gram every 24 hours. Then if the patient is having the risks of MDR pathogen, then we have to combine the drug with this same drug with vancomycin and linezolide. Cephalosporin drugs are imipenem